Okay, Doug, thanks for that. For those people who don't understand what just happened, which must seem bizarre to some people, the Mayor of this borough is apolitical, and for that reason we do not expect them nor allow them to chair things of a political nature. That is the job of the politicians. That's the reason that I'm sat here now. Firstly, can I welcome people to this meeting? Just a quick overview of how I'd like to see it work. This is an opportunity for the NHS to briefly describe their proposals, and I think they've been out there for a while. Most importantly, it is an opportunity for members of the public and people not from Darlington to make their points. Councillors, we've got every opportunity in the meeting afterwards and in the scrutiny committees and elsewhere to make our points. My view is that we should be here to listen to the public and to people who want to make representation. Scrutiny committee and others will consider the STP over time. Sorry, I'm just going through my notes. I've got to say that I'm really pleased with the response that we've had. We've got people from right across the patch, which I think demonstrates the draw and the support that DMH has got, but we'll find that as we go forward. Can I remind people that this is being videoed, so it can go on the council website, so we can get to an even larger audience. If you've got a problem with that, if you let officers know, and they will ensure that your face, whatever your contribution, does not appear on the website. If people are struggling to hear in the gallery, then there is a live stream of the events in the main foyer, if you would find that easier. In terms of the proceedings, what I'm going to ask now is for Ali Brown from the NHS to make a presentation of around 15 minutes, and then get into a section where we've got experts to give their presentation. But the bulk of the meeting today will be about the public, because in my view that's what we're here to listen to. So with that, can I hand over to Ali? In that case, I'll hand over to Alan. Cheers.
Well, good afternoon, everybody. It's a pleasure to be here in Darlington, and I've already been able to meet some old friends and acquaintances that I haven't seen for many years. We've only got 15 minutes because we're here to listen. We want to listen to yourselves and any contributions this afternoon, and that is most welcome. I say that because this is a complex planning process, and we have lots of material we could have shared with you today, but obviously there's a limit to what we can do in 15 minutes. However, some of you will be better informed than others, so some will have already, and I know have already engaged in the process. So we need to try and keep up a little bit of a pace, so I will certainly endeavour to do that. This is the footprint for the STP that I've been asked to lead. What the STP is a planning process. It's no more than that. It's a planning process, and it's a process that is ongoing and evolving. And it's very much work in progress. So listening to you here today will help us to inform the planning process as it moves along. So essentially on this first slide, what it's about is trying to bring organisations together, to develop and plan together, and try to reintegrate some of the services that have maybe fragmented over the years. The NHS is in a difficult place. NHS and social care, it's very challenging at the moment. You don't need me to tell you that. And we see that played out in the news every day. But what we all want, I think, is to sustain the NHS and care system going forward. So we have to meet the challenges. So this is a planning process in response to the 5-year forward view. And as you probably know, there are 44 STP footprints across the country. They're not new statutory organisations. It's coming together to do some joint planning. Therefore, it's an umbrella plan. And what I've been keen to do whenever I've gone out to health and wellbeing boards and to engagement events and to some of the scrutiny events is to say, the great work that councils have done with their health and wellbeing boards and designing and determining local strategies is very much what we need to build on. It's not about sweeping them away. The STP needs to add some value. So it becomes an umbrella plan where we can learn from each other at scale and maybe do things at scale across a bigger footprint that we couldn't otherwise do locally. But localities are important, and more of that later. So as I say, you will be, some of you, more familiar than others with aspects of the work so far, but it does remain a draft. There is more work to be done, and we're working with a vast array of partners. There are 18 statutory organisations on the footprint and endless voluntary organisations that we're working with. What we were asked to do is identify the 3 gaps, or the triple aim as this slide goes. But to a degree it's a moving feast. We still continue to deliver services as the months go by. The challenges seem to become greater. But at a point in time we were asked to say, if we try to predict what will happen in the next 5 years in terms of the demographic changes, the pressure that the social care system is facing in terms of the impact that is having on health, the growing elderly population, the need to deliver a better 7-day NHS, because we do deliver services 7 days a week, but it's not as good as it needs to be, weekends and bank holidays and out of hours. What are the challenges? But not to forget that prevention, lifestyle issues are very much a part of trying to sustain for the long term. So we were asked to look at the health and well-being, and I'm sure as local authorities that are here, you've got all the statistics yourself. We have similar challenges right across the northeast in terms of life expectancy, smoking, obesity and all the rest of it. So we've tried to quantify that. We've also looked at the care quality and the standards, and this is the bit of the programme that we started to do some years ago under the banner of the Better Health programme, because we recognised we wanted to improve standards. We wanted to make sure we got rid of unwarranted variation. We wanted to try and get equality of access to get better outcomes for patients. So the care and quality is about meeting clinical standards, so that if you have a stroke on a Sunday evening, you get the same opportunity for the same treatment and the same outcome as you would if it was 9 o'clock on a Wednesday morning. So we need to look at our staffing, which is critical in that. And then we've got the financial issues. We haven't got a £281 million deficit, but what we've tried to analyse is the demand going forward, the likely increase that we will get from the government, but look at the pressures that the system faces. And if we did nothing, we've valued the challenge, if you like, at £281 million worth of efficiency that we need to try to get out of the system. But when I say efficiency, it's about working smarter, it's about working quicker, it's about using technology, it's about reducing waste, it's about reducing duplication. And as a health and care system working together, I'm sure you will recognise there is some of that we could do better together. So it's trying to put it on a place footing. That would be the analogy I would use. And I know local authorities are very much aware of that concept. So the drivers for change, and there are many. We've got the changing health needs, which I've touched on, increasing expectations of the public, long-term conditions, obesity, some that I've already mentioned, be it heart conditions, obesity, diabetes, pulmonary disease, COPD, and well, the list goes on. You know what all the long-term conditions are. And we still have far too much of the care of those long-term conditions going on in a hospital setting. Equally, we need to invest more in the community. And a big part of this is the third box, care closer to home. We do a lot of care outside of hospitals now, and there's a pyramid triangle that you'll see shortly. But essentially, we've got to do more out in the local community and protect that as much as possible. I've talked about medical advances in the sense of everybody's got greater expectations. We want better outcomes for people, particularly where they need specialist medical care. And we need to make sure in the northeast we're at the leading edge of that in terms of the technology. I've touched on clinical standards. Staffing in social care and health care is a major issue, so we need to use our staff effectively, and that's a major part of this. And I've also mentioned 7-day services and a better 7-day NHS, and of course resources. So, lastly from me, because we haven't got a lot of time, this was the triangle I was referring to. 95% of care locally. The bulk of healthcare interventions are done in primary care with GPs. and that will continue. And as you move up the triangle, it's the real high-end specialised stuff in relation to heart attacks, major trauma, sepsis and the like that need to go into more specialist services. Where we've got critical care support, we can do diagnostics within quick turnaround, and that's where there's some heavy lifting in terms of investment. But it still only represents a small part of the overall service that the NHS provides, and a small volume of patients that are critically ill at any one time. So just really trying to remember that what we're trying to do is keep things local, and we need to do more of that where it's safe to do so. I'm now going to hand over to Andrea Jones, who I think many of you will know, who's going to take us through the next few slides. Thanks,
Thank you, Alan. I'm Dr. Andrea Jones. I'm the clinical lead for Darlington Clinical Commissioning Group. Some of the slides that I've got, I hope aren't new to a lot of people, because we have been on a journey together. The CCG has been in existence for 4 years now, this April, and we've had a continual conversation with the public about what we're aspiring to do, what we're trying to improve for the population. And I do remind people we do have that statutory obligation to actually improve services for our population, so the outcomes are better. And I think that's sometimes lost in some of the conversations that I hear. So I'm just going to go over 4 priority areas, and my colleague Derek Cruikshank is going to touch on one of the priority areas. So the first priority is actually prevention. It's quite interesting how we don't always give the priority to this area, because if we put more attention to this, it will save far more lives than some of the technology and the fancy stuff that we do. And we really need to industrialise prevention. I know that the local authority have been challenged in that mantra. They host public health, and they've been challenged with cuts. But the health service it's an essential element to actually ensure the population is fit and healthy for the future. So this is our first priority. Also, individuals have to take greater care of themselves. I think we should all challenge ourselves. Are we all doing, and are we all living the lifestyle that actually will keep us well and healthy? We need to identify people who are at risk, and there's far more we can do through care planning to actually ensure we predict when they're going to become ill. We actually inform and educate them as to what to do when, and make sure they have support very readily available to them close to home. Also, earlier diagnosis, cancer, a key element of the STP is to ensure that we actually improve cancer outcomes. And by doing so, we have to actually improve the actual detection of cancer. We need to make sure that investigations are rapidly undertaken to make sure we improve on those survival rates. Priority 2, this is obviously dear to my heart and dear to the public, and this is what we've heard repeatedly through the events and discussions we've had over the past 3 years. That actually it's what happens locally is actually of most importance to people. And we do need to make sure we've started on a journey set in Darlington, but in the STP we actually have great insight into how our other areas have been actually transforming their out-of-hospital services. So we have a really good opportunity starting to share that understanding, and actually to spread good practice, and also adopt national good practice that's coming out of all the areas around the country. We do need to make sure that we extend the service in the community. I think a lot of you know that access to primary care has been an increasing worry and concern, and we need to make sure that we actually bolster the teams that actually are out there supporting people, not just increase the number of GPs. We need to make sure that when people do need to come out of hospital, that's done rapidly. We know that isn't often the case, so we need to make sure that support is there to actually care and support people. We also, another critical thing that's come back from the feedback, and again dear to my own heart, is actually mental health support. We've got a very secondary care focused mental health services, and actually we haven't given priority to actually having mental health as close to the community as possible. And it's not just mental health, it's actually well-being and connectedness in the community is actually another key element of good mental health. We do need to improve all that access to health and social care and the voluntary services, and the vehicle we're going to be doing this is actually through developing community hubs, and I'll touch on the next slide about what that means in a bit more detail. So what does it mean for Darlington? These are very broad priority areas for the STP, but for those of you who have been part of our journey so far, we have developed a vision for Darlington, certainly with all our partner organisations, and we've taken that to the public. And we've actually now got a blueprint by which we want to actually deliver that vision. And actually a key element of that is improving access to care. and as the primary care and in the community where people want it most. That needs to be available consistently when people need it. We need to make sure that technology helps support that also, so people can actually access information. What we've heard repeatedly is better communication is required between services and teams. So again, it's a critical part of our strategy, and again, I'll touch on that later. Services that we put in need to be based on patients' need. I've worked in the NHS for 30 years, and that hasn't happened, certainly in my 30 years of experience. We need to make sure everything we do is done with the patient at the heart. So anything that we now plan has to have the patient at the very centre. So as a principle, we've talked about workforce. A large part of what we're doing at the moment regarding the hospital service, which Derek will touch upon, is driven by the workforce in some of our services in the hospitals. But actually, we have got an issue in primary care too. We actually have got a challenge in actually the workforce. And unfortunately, where we are geographically, we have a particular challenge which is different to the north of the region and beneath us because of the universities that actually train doctors. So Newcastle and Leeds are our nearest sort of training hospitals, and that you tend to get people who tend to stay there. So we're sort of in that watershed area where we are a challenge. It is a challenge for us. So to actually enhance the primary care team, we do need to actually adopt different practice. We need to actually embrace the other health professionals we know are out there who can actually sometimes do better than a GP. And I'll use a specific example of physiotherapists. And something we've been actively actually doing is actually putting physiotherapists more front line and actually supporting practices to be seen for more urgent problems. So certainly from April, all the practices will have available. You'll be able to see a physiotherapist within either on the day or within 48 hours of an acute problem. So there's a number of professionals, and I'm aware of time, so I won't expand, but there's a lot of people who can help support and actually create a more expanded team to support the patient. Priority 3, Derek, do you want to just hop in?
Thanks, Andrea. My name is Derek Cruikshank. I'm the in-hospital clinical lead for the Better Health Programme element of the STP. My day job is actually a gynae cancer surgical practitioner, and the reason I mention it is because it's a mouthful, sounds important, but actually it highlights one of the pressures that's occurred in the NHS over recent times and will be an increasing pressure moving forward, because as Alan said, we're trying to plan services that are going to be sustainable into the future. But cancer services have been rationalised since the late 90s in order to improve outcomes with cancer. So you've got specialists like me and a colleague providing cancer surgery for a population of 1 million, which is the current population of the STP. But as pointed out in this slide, the key element to this is that we're actually all in it together. We need to listen to you guys. We're all trying to provide the same output, which is actually better health for our patients, our loved ones, and emphasise the point that's been made previously, which is that the majority of care in hospital will actually be provided locally. It's the minority that we're talking about in the better health element of this. So that if we talk about serious emergencies, life-threatening emergencies, we want to try and provide that with senior consultant presence 24/7 wherever possible across the patch, so the patient gets the expert, whether it's day or night, when it's appropriate that is required. At the moment, we cannot provide that on each of the sites that are providing acute care, and that's one of the pressures. As a consequence, we also want to provide planned care, that's elective surgery, on a dedicated site that will not have procedures cancelled because the emergency work blocks those beds. And I'm sure many of you in the audience will actually have experienced it yourselves, or have someone close to you that have had procedures cancelled. We're aiming to try and avoid cancellations. This slide is really just to focus on the bit in the middle, which is all these specialties are provided currently across 3 or more sites. All our organisations are trying desperately hard to meet the ever-increasing, and quite rightly, standards that the public expect of us, but are beginning to fail and have difficulty meeting all the rotas of all these specialty services. And that's a big pressure that requires a change in the way that we deliver our services. Again, better care for our population, 24/7 where appropriate. I'm not going to go through this in detail because of time, but if you just focus on the future column, again at the front of this, we want better, safer care in the community so that patients aren't in hospital unnecessarily, they're not having prolonged stays. We know that the longer patients stay in hospital, the more likely they are to be harmed, the more likely to be adversely affected by that. We want to provide care and facilities for them to get home sooner. Planned care, as I've said, ideally we want to have no cancelled operations. Currently at this point in time, because of the pressures of winter, we've got patients with cancer that are having procedures cancelled because of the pressure from emergency care. The bit at the bottom, the safer emergency care, at the moment patients have to wait sometimes until the next day or after the weekend till Monday to get tests done. We want to have tests available 7 days a week. We want the patients to be seen by a senior decision maker, a senior practitioner, and we want that presence to be there for longer than it currently is on the sites that we currently provide that care. And I'm going to finish off with this slide before panning back to Andrea, because I think this is the nub of it. We've already got specialist provision with the James Cook site for major trauma, and that's an example of the sort of changes that have occurred that have demonstrated that we've improved outcomes with major trauma being provided centrally, meaning that patients now have to pass by their local A&E to get to the major trauma centre, but the outcomes by doing that are actually improved. So with that change in service provision, the 1 year mortality for major trauma has actually been improved by 30%. What we need is a second emergency site either at Darlington or North Tees, and I emphasise at the moment, although it's in the press, there is no decision being made about that. That decision is yet to be made. We need to engage, we need to listen to the views of our colleagues, of the public. Andrew will finish off with how that process happens. And I'm going to finish off by saying that, again, emphasising that we need to shift a lot of what's currently provided in the hospital into an out-of-hospital setting. Thanks, Andrea.
Thank you. I think the key element for me is actually the workforce issues that have driven this initial piece of work, and the importance of, because the services are becoming stretched, I think that sort of prediction is now coming to fruition. Initially, we were both at a meeting yesterday where consultants were there and actually describing how it actually was. And actually that then challenges you to actually recruit and retain people. So if you're in a very stressed situation where you're having to cancel operations, I think we had somebody cancel 3 times, was quoted, for a cancer operation. It's not a pleasant place to work in an environment. So it needs sorting to actually ensure we attract the best possible workforce to our area. So how are we going to evaluate all this? As I say, we are in the midst of the process. I'd like to repeat again that no decision has been taken. And when we do get to do that evaluation, the 3 key elements are there in the centre. So it has to be clinically sustainable. We'd all love it to be different. We'd all love to say that we're awash with consultants battling to come into our hospital services. But it is what it is. So actually we do need to make sure that we're actually planning for the long term. We need to make sure that we have the support around the hospitals, particularly the community, to actually really bolster what the patients are telling us they want. And we've had a culture of very hospital-focused care, and I think nationally there is a drive for that to be far, far different, and it will be, I believe, far better. We need to be able to implement it. So again, some of the practicalities of actually being able to physically actually implement some of these things, which creates some of the issues about how much capital we've got to maybe actually support some of the changes that are going to be required. And as you get into the complexity of the clinical discussions, some of those issues start to tease out. So we're still already, even at this stage, still considering multiple scenarios within the scenarios. And as I say, there's still as yet no clear decision behind that. It has to be financially sustainable. Again, we'd love it to be different, but we are where we are as a country. And as you had described, we have got a gap. And I'd like to repeat, because I think in the news today it's actually saying cuts in the NHS. There are no financial cuts. What is happening is that the increase in spending is not keeping pace with an old-fashioned way of working. So that gap is, if you stop working in an old-fashioned way and start to actually work in that different, smarter way, then that's where the gap can be closed. So in that circle around are all the issues that are driving the conversations, the standards that we started off looking at. These are national standards that often relate to hours of presence, of consultant presence, also to how many procedures you've done, which you need to improve your skill. The workforce, again, is a key driver for the work they've been doing. Travel at the bottom there, again, a key element of our discussions. We hear repeatedly about the anxieties and concerns of the public, and we hear those very strongly. Finance we can't get away from. I'd love to say, and I wish the political conversation was better, as actually how we're going to square the circle. I do think there needs to be increased funding coming into both NHS and social care. That's my personal view. But we can actually do things, and we can change things for the better in the environment that we're currently in. And it has to be achieved within 5 years. As I've mentioned, our services are becoming difficult to sustain here and now, so we actually need to get on with it. So the next priority is use of technology. Again, repeatedly being asked by the patient, why do we have to repeat our story? Why do we have to say it all again? And actually the safety of not having the clinical record, which is very rich in primary care, is not present necessarily across all the services. So there has been a commitment across the whole of the North East to develop the Great North Care Record. We have an interim solution, which it's been started this year, so secondary care can actually view the general practice record, with the patient's consent, of course. But also, how can we actually modernise the way we actually consult? You do sometimes need to have a hands-on from a clinician, but it doesn't always have to be the case. So you can consult remotely. You can actually assess somebody remotely. And as one of the strengths of a clinician is your intuition by actually seeing the patient. So telephone triage has a challenge that you can't see the patient. But we have technology now. We have smartphones. We have iPads. It's very easy to be able to actually clinically assess somebody better by having that visual element. And also having consultants networked across the geography to ensure clinicians who may not be right on the doorstep of a hospital have the best possible support by a specialist to support that patient. And also patients maintain their independence. Again, there's lots of technology that can help people to self-manage, and again we just need to industrialise that. It won't be for all. I'm aware we have a generational issue about technology, but we need to be embracing technology far more. So the steps, we are still engaging, so no decision we're taking, and as we've been said today, today's really important to hear those views and voices. We're still building on existing work that we've been doing with our partners, particularly our local authorities. We have projects in the Better Care Fund. We have an exemplar. We are a Healthy Newtown exemplar nationally, supporting the Eastern Corridor of Darlington. We want to support the voluntary sector to become far more robust. And again, they've been challenged, I know, with the local authority situation financially. But part of our plans is very, very reliant on having a robust voluntary sector there to improve the well-being of our population. I've touched on the Darlington Blueprint, so I won't expand more on that. I think we've covered that. But the integration agenda, you know, we constantly hear people complaining of the fact that they get bounced between organisations. That has to stop. So that's a key part of our planning. As part of our process, we do need to submit a draft business case to NHS England. That capital we've talked about, there is again a limited amount of money. We need to be fairly prompt in actually getting our request into this area. We're told in a good place that actually if we have a good plan, that we'll be listened to, and hopefully will actually attract that funding for our area. And obviously we're planning for public consultation. That's the formal process that we go through. Obviously once we've digested all the issues, we've had far more rich conversation with our clinicians, because I'm aware there's still a lot of outstanding work and detail still needs to be done. Some of the pathways that actually will refine the model. So there's a lot of work still to be done. But once we're clearer actually about what we think that the issues are and the preferred option is going to be, we need to turn to the public and say, actually, having considered all these issues, all the complexities, this is what we think will actually deliver the best results for you. And that's the end of the presentation. Do you want to summarise anything? Or? Okay, thank you.
Okay, no, thanks.